understand their child's context. For instance, if they have travel plans or hear that their friends and family had minimal negative reaction to the vaccine, they may be more inclined to vaccinate themselves. During the interviews, they saw newer vaccines such as rotavirus as more risky than the older ones, since the older ones had been around long enough for the long-term side effects to be discovered, but the newer ones hadn't. Some of these moms were also hesitant about putting an artificial or foreign substance into their child's bodies, which they viewed as pure. They also feel that the naturally acquired immunity is better than immunity acquired by vaccines. Another key takeaway is that these moms feel their healthcare providers were too biased in the information that they provided. By that same logic, they also felt that the anti-vaccination sources were also too biased. They felt that CAM practitioners, otherwise known as alternative medical practitioners such as homeopaths and acupuncturists, provided a more neutral view because they talked about the potential side effects more and less about the herd immunity benefits. These moms felt pressured by the healthcare system to vaccinate, and so they felt that it was in the healthcare system's best interest to see these vaccinations numbers rise. This information can change our practice. We could greatly increase our vaccination rates if we used a logic for vaccination that took the same approach, this individualized approach, as these vaccine hesitant moms.
The next study here is a qualitative study which talks about parents' experiences and nurses' perceptions of decision-making about childhood immunization. The purpose of the study is to further understand parents' and nurses' experiences of decision-making about childhood immunizations. Moving on to the sample characteristics, there were 6 nurses and 16 parents, which 9 were pro-vaccine and 7 were anti-vaccine in northeastern Ontario. And the sampling criteria were that the nurses involved in the study should also be involved with childhood immunizations. For the parents, they are to understand and speak English, aged 18 years or older, and be the decision-maker of immunizations for their child within the past 6 years. This article used Thorne's interpretive description, which in the study is the use of an interviewer who has a public health background but puts her profession in suspension for the purpose of conducting the interview without any bias. They conducted 1-hour recorded focus interviews to explore the experiences and perceptions of nurses and parents regarding immunizations. Convenience sampling was initially used to find participants for the study. However, this method didn't capture a diverse range of parents, particularly those who were harder to reach, resulting in a loss of variety for the study. To address this, snowball sampling, where existing participants refer others, was used to reach parents who did not use clinic services but could provide valuable insights on delaying or refusing childhood immunizations. The outcomes of interest of the study on the parents' side is for them to look back at their decisions to accept, hold, or decline the immunization of their children, and how they felt about this decision in the past and present. For the nurses in the study, it's about getting a better sense of how they discuss immunizations with these parents, and how they see their role in helping parents make a well-thought-out decision. The findings of this article outlines 3 main steps for the parents' decision-making about childhood immunizations, which is the searching for information, the deliberation of trustworthiness of said information, and bearing the responsibility for decisions. Information gathering phase, parents often turn to healthcare providers, research reports, experts, and other online sources. However, some also rely on social media, blogs, celebrity opinions, or the personal experiences of family and friends. During the deliberation phase, parents assess the credibility of the information they've gathered, such as healthcare organizations, providers, and celebrity activists. Trust in healthcare providers varied, with some parents feeling confident in their expertise, while others were skeptical about their knowledge and how well they were informed about vaccination risks themselves. In the study, we also found 3 main findings from the nurse's perspective. First, the nurses are often balancing ethical considerations by supporting parents' decisions while also advocating for public health. They recognize the importance of respecting parents' autonomy in making informed choices about immunizing their children, even when those choices are different from their professional recommendations. Second, these nurses are aware that therapeutic communication is important as it builds trust with parents. They understand that clear, compassionate communication can help parents feel heard and supported in their decision-making. Lastly, the nurses are mindful of establishing a trusting relationship with the parents, which is essential for ongoing dialogue and ensuring both the child's well-being and the broader public health goal. This study has several strengths. It uses an insightful qualitative approach that captures subjective information, providing a deeper understanding of the thoughts and experiences of both parents and nurses. This study also identifies key barriers to vaccine uptake, which can help form better strategies to improve immunization rates. Finally, the findings are highly relevant to clinical nursing practice, offering valuable insights for nurses working in public health. However, there are some limitations. The sample size is small, which limits the generalizability of the findings. Additionally, there is a lack of demographic data, making it unclear if the results apply to a more diverse population. Lastly, potential researcher bias could be a factor, as the interviews were conducted by someone who has a public health background.
Synthesis of the sources. We had 1 quantitative study and 3 qualitative studies. A big theme in all of the studies is that they were all trying to understand the parents' point of view and their rationale. Whether it was a survey or interview, they made it clear that they were just trying to collect data and not influence the participants' decisions. This was helpful towards our case study because it allowed the participants to speak and not feel judged, giving us information on understanding these parents and the ways that they think. There was a large variation of sample sizes. The smaller the sample size, the more personal the data, but the 1-hour interviews only met once, and the others were reached out to several times or in different ways in order to see if there were any changes in opinion. Often there were not. This helped our research question, as we know the probability of a person changing their minds after they have made it up is slim, because the studies show that those who were either super anti-vax or super pro-vaxxed stood strongly in their position, and those who felt unsure to begin with felt unsure after the check-in. The final outcome showed that people's opinions of vaccines were highly influenced by what the people around them, such as friends and family members, thought of vaccines, as well as if they thought negatively or positively of the healthcare system. Many people reported feeling that nurses were biased or pushy, so they struggled to take the information from them. This relates to our PICO question, as when talking with people about vaccines, it's important to remember to not come off as judgmental and explain where you are getting the information from. Shortcomings in the articles we researched were small sample sizes and limited demographics, which overlapped but did not match up with our demographic of parents of young age school children. It is important to keep this in mind, as people in Quebec or Ontario may have very different opinions on vaccines than those of Albertans. Overall, the information gathered from the articles can help us explain the importance of vaccines to school-age children parents by making sure that we do not come off as aggressive, pushy, or preachy, and trying to understand their perspective. Overall, our team was communicative and hardworking. We were very prepared, meeting weekly to discuss how we would effectively and fairly split up the tasks, then divided and conquered, making sure that all of our tasks were completed by the time we next met up. We had no problems with dividing up the work or group conflict. We were all in a very similar mindset of wanting to get the project done as efficiently as possible. The consensus among the group was that we learned a lot about why people do not vaccinate their children, as well as how we as nurses can change the way we interact with patients to not come off as preachy or judgy. All in all, this was a group project we enjoyed due to the great team and knowledge we learned along the way.
Group contributions. Lauren worked on study number 1 and the discussion and development of the PICO question. Kelly researched study number 2 and did the outline of group contributions and reference list. Natalie researched study number 3 and explained the rationale for our chosen search criteria. Cecilia worked on study number 4 and explained the outcomes of our search. Amelie did the synthesis of our findings and explained how our studies connect and answer the PICO question. We all worked on the reflection, voiceover, and slides. These are the references we used. Thank you so much for listening.